Hello, everyone. My name is Wenchang Wong. I'm a radiation oncologist at Prince of Wales Hospital in Sydney. Up to the penultimate session of the day. So we've heard some exciting talks in the morning with breakthrough systemic therapy options. This session we'll be focusing more on the local treatment of radiation oncology. Our speakers of the day on the program, Dr. O'Day is in Oncology. So we have Dr. Lotte Fog presenting their talk. First up, Dr. Lotte Fog is a medical physicist who's worked with ocular brachytherapy for 20 years in several countries and Australian states. She works at the Royal Victorian Eye and Ear Hospital and the Alfred Hospital in Melbourne, and is proudly part of a team which uses a multidisciplinary approach to deliver the best possible patient care. Her topic today is delivering world-class patient care. Over to you, Lotte.
Thank you, Wenchang. Can you see my screen?
Yep.
Awesome. Let me just get into presenter mode. There we are. Thank you very much for the kind introduction. And I'm sorry my camera is not working. I've been trying to fix it all day, but you can't see me, I'm afraid. I wanted to thank you, Wenchang, for the introduction, and also to thank AOMA for inviting me to speak here today. So as Wenchang mentioned, I'm a medical physicist with a particular interest in radiation oncology, and I work here in Melbourne at the Eye and Ear Hospital with the Ocular Oncology team. And also, as Wenchang mentioned, this talk should have been done together with Dr. Rod O'Day. Unfortunately, he can't be here, so I'm all you're going to get. My topic today is how we deliver world-class care to our patients here in Melbourne, and that's something that I'm very proud to be speaking to you about. Here in Melbourne, we have improved the way that we work with our patients, both in terms of treatment and in terms of patient sort of through flow in the last couple of years. And what I want to do today is to share with you just how we've done that. You might be wondering what world-class healthcare is. There's quite a few different definitions of it out there. And this one is actually one of my favorites. It's from the American Journal of Medical Quality. And it says world-class healthcare is achieved by going above and beyond to bring the best of the art and science of medicine together. It is achieved when highly skilled professionals work together as practice teams with precision, passion, and a palpable commitment to excellence. I think this is excellent. It speaks of teamwork, of passion, and of commitment to deliver the best possible care. In my opinion, it's how we should be all approaching healthcare. You might be wondering what this looks like for the typical patient. And for the typical patients, the flow through from diagnosis to treatment looks something like this. The patient is diagnosed at about 10 o'clock on this screen. Imaging is acquired. We've got an Optus image and an ultrasound image here. Then the treatment is chosen. And in this case, our patient has a plaque, and then the patient is followed up. And if you squint at the follow-up image, that's actually Dr. Rod O'Day. So he's at least here a very small amount. So this is what probably happens to most patients with ocular melanoma. As I mentioned, in Melbourne, we've worked very hard the last couple of years to give our patients the best possible journey, and that means doing more than what you see on this slide. So what we do in Melbourne, we have multidisciplinary team meetings, or MDMs, and I'll talk a little bit more about them in a moment. Our patients have access to systemic therapy through either the Alfred or the Peter Mac. We have access to image-based radiation planning to try and determine the potential benefit of that systemic therapy for our patients. We have a very dedicated ocular oncology nurse consultant, and I'll talk more about her in a minute too. And finally, we do a lot of systematic data collection for benchmarking so that we can keep an eye on our patient treatment parameters and also on our patient outcomes. I'll talk more about each of these in terms. So first of all, the MDMs, the multidisciplinary team meetings. They are meetings where all the relevant professional medical staff come together to discuss each patient in turn and what treatment would be very best for them. And and for ocular melanoma patients, this is actually really challenging. The relevant medical staff for us includes ophthalmologists who are probably taking time out of a busy clinic to attend the MDM meeting, a clinical nurse consultant and fellows and registrars who might be at the Royal Victorian Eye and Ear Hospital doing something else that day. It includes radiation oncologists who for us in Melbourne work from the Peter Mac, medical oncologists who might join us from the Alfred, from the Peter Mac, or from the Austin, medical physicists who might join from the Peter Mac or the Alfred, and pathologists who typically for us are located in Sydney. It is incredibly logistically challenging to do. And you might wonder why we bother. We bother because multidisciplinary meetings, multidisciplinary care provides very clear benefits to patients. And I've included on the right there some information about just what evidence-based benefits MDMs actually provide patients with. The patients see increased survival rates, and they see a shorter time from diagnosis to treatment and better outcomes. And that's just the patients. MDMs actually also provide benefits to the professionals involved in terms of them feeling much more comfortable about the treatment that they deliver and happier in the knowledge that their patients get the best possible care. And here in Melbourne, these happen regularly, involving all the people listed on that diagram. MDMs. There is an ongoing Australia-wide research study exploring the potential benefit of systemic therapy, and we've talked quite a bit about that here today. The systemic therapy can be given prior to treating the tumour in the eye. The goal of this would be to either prevent the need to remove an eye or to reduce the vision loss caused by treatment. This is a very exciting and novel approach to treating patients with large uveal melanomas, and it's only possible with close collaboration between medical and surgical teams to ensure that it's safe for patients and that the best patients are identified for this treatment. The paper I've included on the right is a case report on one of our first patients from Melbourne. This patient had an uveal melanoma in his only seeing eye, and it was too large for plaque brachytherapy. Systemic therapy was used to reduce the tumor to a size where we could actually treat him with brachytherapy and he could retain some vision in that eye. Sorry. Some tumors, like I mentioned, are too large for plaque brachytherapy. And sometimes the radiation dose to sensitive structures in the eye, such as the optic nerve and the fovea, are so large that the patient's vision are very likely to be affected. For such patients, the use of systemic therapy may be used to shrink the tumor prior to brachytherapy, so that plaque brachytherapy becomes possible when it otherwise wouldn't be. Or it might be used to shrink the tumor such that the radiation dose to critical structures in the eye becomes less and the likelihood of vision being affected is reduced. This is all great, but the only way that we can really assess how changes to tumor size affects the likelihood of toxicity is to use a particular piece of software, an image-based planning software called Plaque Simulator, which allows us to predict the radiation dose across the entire eye. The picture on the right of this slide shows a calculation like that. You can see the optos image. The optic nerve is the bright spot, and the tumor, which is a dark spot near the top of the image, and an iodine plaque, which is shown in cyan. And because we talked to the other plaque brachytherapy centres in Australia and New Zealand, quite a lot of them are actually starting to look at implementing this software in some sort of clinical workflow, which is very exciting for me professionally. These are photos of another of our Melbourne patients. This patient presented with a tumour with a height of 11.4 millimetres, too tall to treat with plaque brachytherapy. This patient had systemic therapy, and you can see how the tumour has shrunk in the middle picture. Look at the distance from the dark tumour edge to the optic nerve. After systemic therapy, the tumour shrank to 8.4 millimetres, and we treated this patient with an iodine plaque. The radiation planning for plaque treatment is shown in the last image, where the optos image is the same as the second image, and the brown contour shows the tumour edge. For this patient, we calculated radiation doses to the optic nerve, 62 Gray, if you care about those numbers, and to the fovea, which was 82 Gray. And this helped us understand the likelihood of toxicity and be able to advise the patient accordingly. For the last 2 years in Melbourne, we've had a clinical nurse consultant working with us, Peter Holly, who's shown in the top right-hand picture. She works with the Ocular Oncology team, and she supports patients inside and outside clinic. She also does a lot of work to make our clinics run more efficiently. Since she started with us, our clinics have run much more smoothly, with increasing patient numbers in each clinic, with no increasing waiting time. Holly also makes referrals to supportive services, something quite a few of our patients need. The patient's journey, as we've heard in lots of really wonderful talks today, from diagnosis through imaging and treatment and follow-up can be quite overwhelming, and Peter does a wonderful job of guiding the patients through it. I could tell you in my own words how much I think it means, but I don't think I can say it as well as one of our Melbourne patients does. And this video was played at last year's AOMA. He said about our clinical nurse consultant, about his cancer, it doesn't just affect you, it affects your family too. I think there's a gap between patient, treatment, and doctor. This gap is being filled in Melbourne by a clinical nurse who gets to meet you and gets to know you. That's huge. We're very lucky to have this service in our clinic. It's useful for clinics to keep an eye on their treatment and outcome data to make sure that there's adequate resources and to make sure that the outcomes are excellent. For the past couple of years, the Ocular Oncology team here in Melbourne has had a database manager, that's me. I produce an annual audit report, and you can see a couple of the figures from the 2023 audit report at the bottom of this slide. You can see that our clinics are busy. We saw 582 clinic patients in 2023. And as we've heard, that we treat patients not just from Victoria, but also from Tasmania, South Australia, New South Wales, and even the ACT. We keep a very keen eye on our recurrence rate, and we, at this point in time, feel fairly confident that it's low compared to published figures, something that makes us very happy. Anthony Joshua has talked about registries several times today, and we feel it's very important that we contribute to these registries. We've contributed quite a number of patients now to the Fight Tumor Blindness Registry, which collects data on ocular melanoma from multiple clinics and will become a valuable research team in the ocular melanoma space. We received feedback from a number of our patients that they would like more information about plaque surgery, which is the most common surgery for uveal melanoma. Prior to actually having the surgery, this seems very reasonable. We had patient information regarding our other surgeries, but not about that surgery. Listening to that feedback, we've started a project with the help of WICMIX, help and support, I should say, of WICMIX, to create an education package, which is in fact nearly complete. We had our last meeting about it only yesterday, and soon we'll be able to provide some information videos for patients. This process has been heavily involving our patients for their input, as well as other stakeholders to make sure that it's a well-rounded package, and hopefully we'll be making it public very soon. And no, this isn't a mistake. This is the same slide that you saw earlier. It shows the simple workflow for a patient diagnosed with ocular melanoma. In Melbourne, though, we've added some extra steps to this. So here's the Melbourne pathway. We have an MDT or an MDM and the possibility of radiation planning using Plaque Simulator before the patient chooses their treatment, so that that choice can be as well informed as possible. Our patients are supported by our clinical nurse consultant throughout their journey, and we keep a very close eye on our outcome data. We continue to strive to further improve this. And so in closing, we've chosen to adopt a very multidisciplinary approach to our ocular melanoma patients. This benefits our patients and our staff. And on the right again, I've listed all the different professions that are involved in this. It really is, for any medical procedure, quite a multidisciplinary space. We continuously strive to continue to improve. And I would really love to point out at this stage that the progress of our team here in Melbourne is to a large extent due to the vision and the hard work of the head of our unit, Dr. John McKenzie, who I really hope is listening to this. I've included a couple of references, which you might find interesting. And at this point, I would like to invite questions. I finished a bit early. Sorry, Wenchang.
Yep, thanks, Lotte. Yeah, thank you. Well, maybe we'll have the questions at the end of our session with the Q&A. Remember, everyone to type in their questions in the Q&A box, not the chat box. So we have time. Well, I'll move on to my talk. Let me get my slides up. I'm Wenchang Wong, the radiation oncologist at Prince of Wales Hospital in the Naloon Comprehensive Cancer Centre in Sydney. I'm part of the oncology MDT or tumour board. So the main radiation oncologist involved in uveal melanoma or ocular melanoma management. Took over the Prince of Wales program when I became a staff specialist in 2007. When I became a permanent staff specialist in 2007 at Prince of Wales Hospital, and developed the program that we'll be talking about henceforth. So the title of the talk is Advances in Radiation Oncology and the New South Wales Experience. There's was a title thought of by the organisers originally, and I thought, well, that's an apt talk. Well, let's proceed with that, and I'll come up with a talk. Hopefully, it corresponds to the title. Some of the slides, I realised, will be sort of rehash of what Tim had already given in just the previous session. But just to go ahead, the eye is the second most common site of melanoma after the skin. It only accounts for less than 5% of all melanomas, but it's the most common primary malignancy of the eye in adults. So when we, as Philana was saying earlier, when we say melanoma of the eye, it could mean a lot of things, but majority would do mean choroidal melanoma, as that accounts for all the uveal melanomas, the other ones being the ciliary body and the iris, as seen there. Incidence, it is very rare. Depends on the literature, what you read. It could range from 4 to 8 cases per million per year. Patients always ask, is it due to sun exposure or not? But it's interesting fact is pale eyes, light color eyes, pale skin towards Scandinavia. So increases of latitude of in Europe rather than going down towards the equator. So it's an interesting fact. Predominant just of male predominance versus females, median age in the 60s. So back before the 1980s, the most common form of treatment was surgery, and that is removing the eye. And we've heard how devastating that is for patients with their eye removed as part of their curative treatment. But then plaque brachytherapy was starting to come through and found that this achieving similar local control. So that's when a major trial started in the late 1980s, going to the 1990s, as Tim said earlier, the COMS trial. We use the acronym COMS. And that you can see in this graph here, a publication a few years ago looking at the SEER database, which is an American database capturing most of the community treatment for ocular melanoma, in particular this case, uveal melanoma, showing this transition period here of the uptake of plaque brachytherapy versus a downtrend in surgery. And it really crossed over when its publication came through in the early 2000s, showing that brachytherapy versus enucleation has similar control and same survival. So no detriment in survival. That was the aim of the trial. There's no detriment in survival using plaque brachytherapy. So the advantage of plaque brachytherapy, obviously, is eye preserving, preserves the eye, achieving similar control and survival to surgery. It preserves the function, not just the vision, but also the look, cosmesis, which is equally important in terms of survival for some patients. So Tim's already mentioned this. The plaque brachytherapy does involve operating theatre time, general anaesthetic, so as it could be done as a patient discussion earlier. So it was under sedation, local anaesthetic. They are inpatient for the whole duration of the treatment when the plaque is inserted over top of the tumour on the eye or the sclera. So it's called episcleral plaque brachytherapy or plaque brachytherapy or plaque in short. And depending on the radioactive decay of the source, either iodine-125, which is sort of seeds which are put in these pre-filled slots of a plaque, which is the dish, or ruthenium-106, the radioactive isotope, which is the whole surface is radioactive. So depending on the decay for radioactive iodine in particular, it's only about 2 months half-life. Half-life of ruthenium is 370 days. So depending on the decay, it could take anywhere from 2 or 3 days to up to 6 or 7 days. We don't want to go any further, more than a week. That means the cumulative dose on the surface can be quite high. If they are treated in a single room, there's radio protection of the staff. That's just minimized time in contact with the patient. And then once the dose is delivered, the ophthalmologist takes off the plaque and gives it back to the physicist who is there to take it back in the lead line safe to avoid carrying the radioactive isotope around town. So plaque brachytherapy is effective, and this is some data that I actually updated when I took over the program, and it's actually updated in about 2007, 2008. So it's presented in abstract form previously, but updated and data is not published yet. It's all based on iodine-125, not including the ruthenium plaques, just was the data was not, there was a loss of data in the ruthenium ones. The local recurrence-free survival, that is local control, is about 95% at 5 years. The eye is conserved or preserved in 92.4% of the cases. Of the 317 patients in this database, 24 were enucleated. 14, 4.4% overall was for recurrence or progression in the eye. 8 patients, 2.5% of the total cohort, had enucleation due to toxicity, mainly from neovascular glaucoma, causing pain. And it was 2 that undocumented as to the reason why they had the enucleation. Importantly, how good is preserving vision? It continues to deteriorate due to the radiation side effect. It's preservation of useful vision, defined as 6 on 60, or not worse than 6 on 60, is about 43%. So about half the patients retain some vision. It does deteriorate. So at 3 years, it was 64.5%. 2 years later, another 20% lost their vision, worse than 6 on 60. Importantly, cancer-specific survival, so dying from the uveal melanoma, is only less than 10% in this cohort. Overall survival, 81%. Overall survival is worse. This was the age range. Patients have been treated in this cohort. It was 21 to 91 years old. Most of these patients, over 300, about 300 were all in the medium thickness lesions, we call it. There's mean maximum thickness is 5.4 millimeters, mean maximum diameter of the lesion, 11.3 millimeters. So what about those other patients who can't have brachytherapy? Back before 2000s or early 2000s, I'm not sure how scientific this figure is, but we calculate that 80% of all patients that are diagnosed in Sydney, New South Wales with choroidal melanoma, 80% were having brachytherapy, another 20% were having enucleation. We'll go to reasons why that is. So the question was asked of us, can we give external beam radiotherapy? We can't. Some patients up to that point in time were being sponsored by Australian government overseas for proton therapy, but not everyone fulfills the criteria. A lot more don't fulfill the criteria and can have local treatment with external beam radiotherapy, utilizing the machines that we treat for every other cancer, every other solid cancer in the body. So that's when, why is that? Well, it's because those patients were not suitable for plaque brachytherapy due to the size. Was this really a defined size of the plaque that can be fitted in orbit? We have a maximum 18 millimeter size, ruthenium, iodine-125, and a maximum 20 millimeter ruthenium diameter plaque. But the effective radioactive zone is about 2 millimeters, 1 millimeter on size. So a 20 millimeter plaque would be only 18 millimeter maximum size, and that's without allowing for a margin error of placement of the plaque over the surface of the sclera over the top of the tumor. So this patient, from this photos of patients that previously had transperineal thermotherapy and then recurred or progressed a few years later, and to the point was wrapping right around the optic nerve here. So all this disease here, and you can see that on mouse pointer. And this other patient whose initial presentation with melanoma there, going from 3 o'clock to 9 o'clock of the optic disc. So right next to the optic nerve, we call peripapillary or juxtapapillary. The patient that's difficult to put a plaque over, or can't put a plaque over this one, was wrapping right around the optic disc. And this one, perhaps, with what's called notch plaque. But even then, when it was too occupying so many clock hours, the plaque may not work. So that's when began our program called stereotactic radiotherapy using external beam. So using a linear accelerator, using external eye fixation system, and reserving surgery for those patients who have progression of disease or indeed complications. Right, so it's an outpatient treatment, different from plaque insertion. In inpatient, in operating theatre time, that's the photo there. It's a typical machine, and the patient lying there, the machine rotates around and delivers the radiation. And we've got various almost diagnostic tools to assess the position of the patient. This is a photo off internet, so it's not representative of the actual patient on treatment for choroidal melanoma. So the patients were referred because they had peripapillary or juxtapapillary location next to the optic nerve, where placement of even a notch plaque would result in inadequate tumor coverage, that is underdosing, or even getting a lot higher, very high dose over the optic nerve without and still compromising on tumor coverage. Or lesions, that's what we start off with. And then as we gain experience and similarly good control of those patients right next to the optic nerve, we are asked to treat, well, what about patients whose disease is too large for plaque brachytherapy? Before, there's exciting systemic therapy options where you could potentially downstage, reduce the size of the lesion, and then proceed to plaque came aboard. So we've been treating those patients, location of the tumor just not suitable for even putting a small plaque in. And so some patients not wanting their eye removed. Not that many, but that has happened. Essentially now we can treat all tumor sizes using stereotactic technique. And how do we do that? Well, so the head roll, if you lie in the bed, the head rolls and the eye moves. So we have to make sure the head is kept still so the patients don't turn around during treatment and avoid radiation beam going through. We have to fix the eye gaze so that looking at a spot, they can still blink. You blink spontaneously, the eye doesn't move. And as long as we can do that, we have measured initially by a physicist that we are within 1 mm of accuracy of where we need to treat. So when we first start off, we basically translated what we do for intracranial metastases, treating brain lesions with stereotactic radiotherapy. The reason called stereotactic is because it's a reference, and this is one of the frames we use for that. We have a 3D coordinate for that. The reason we couldn't do it earlier is because it was difficult to do this. The bars get in the way when we put the instrument over the equipment over the head. And as technology allows us to do a lot more imaging on treatment, it's allowed us to do this with this what's called relocated head ring. But the problem with that is we have to get them to bite on this block to stop them from nodding. They can't turn their head, it's not, but they have to bite on this block. They've got to have good teeth. They have a denture, they can't wear it because the gum doesn't bite down the block and it moves a bit with their head tilt. So we can use this mask. It's not as comfortable and difficult to position the camera. So there's two different things that we used initially. With the camera, we monitor the eye position, and next to the camera is a light diode for them to look at. But of course, the patients present with poor vision. And so that's a bit of difficulty. And in a few patients, we've had to move the camera to the good eye so they can see the light and concentrate on looking at that light diode. The opposite eye uses a surrogate, was both eyes move at the same speed or same direction. But that's not ideal, but that's what we had to come up with. And in the early days, how do we monitor that? So we take a template of the eye position. As we just text them up, that's this patient on treatment outline the eye position. I've had to color the pupil so that recognize this patient, but the pupil is also outlined, or the eyelids outlined, even where the eyebrow is, so that we then use that as a template. And when patients actually get our treatment each day, we align to that position. And a lot of people watching on the monitor to ensure that if there's any deviation, the radiation beam is turned off and ask the patient to fix their gaze again. How do you know we're treating the right area? An MRI is very good for this. So for this patient, the MRI shows the enhancing component. You can see these patients, our patients with the juxtapapillary right next to the optic nerve here. And MRI is very useful, especially those patients who've got serous retinal detachment. So the serous fluid does not enhance, but the melanoma enhances. So on a CT scan, we won't be able to see this. On a MRI with gadolinium contrast, we can see that much better. And we marry these up with the fundus photos from an ophthalmologist. How is this treated? Patients have 5 tumors in an outpatient. Beam on time is probably 10 to 15 minutes, depending on how big the lesion is, how many angles, how many different angle beams we have to go through, all up from entering the treatment machine to leaving treatment machine in about half an hour. As said, this is just representative. This diagram on the left shows the planning scan with the radiation lines or dose right around there, falling off very quickly. That's the beauty or advantage of stereotactic radiotherapy technique, is that you get a concentrated high dose and the tumor, and rapid dose fall off towards the end. So 50 gray is this yellow line here, and then this is 2 gray, 5 gray at the periphery. A lot lower or less. This is the lens here, and this is a representation of the different angle beams going in, concentrating to the tumor and accumulating dose at the tumor at the melanoma site. So how do we do that? Well, there's the linear accelerator. These what's called leaves or mini multi-leaf on the machine, and we collimate or shape the radiation or shape the field to the shape of the tumor, basically, and get a nice radiation dose falling right in the middle, and very quick rapid dose fall off out towards the periphery, minimizing toxicity. So this results were updated just last couple of weeks. Our program started in September 2012. I actually presented our initial three-year data at the 2015 biannual International Stereotactic Radiosurgery Society meeting in Japan of our first 3 years data. So it's updated, but essentially now we're treating about 10 to 17, 18 patients a year. So just over 1 per month. As of end of May, we've treated 194 patients in the last 11.5 years. As I said earlier, we start off initially as periphery, and now moving on to large lesions, not suitable for brachytherapy, even lesions that are located on the choroid, on the ciliary body, not suitable for PLAP, patient refusing. And now the past 2 years, patient not wanting to have enucleation after progression after brachytherapy, we treat a few patients, retreated patient with external irradiation after they had brachytherapy. We've had a couple of teenagers in this group, and the 96-year-old was independent, living at home alone, so she was included in the treatment as well. So unaudited results, but 1 nucleation for persistent disease, 1 patient requested for nucleation because they still experience symptoms that bother them. We have had 3 patients, maybe 4 in the correspondence recently, with painful glaucoma, painful blind eye, basically. And it's the only way to fix that is removal of the eye itself. So coming to end soon. Treatment's well tolerated with stereotactic radiotherapy. Temporary symptoms, tiredness, eye discomfort, conjunctivitis, depending on the location of the tumor. So loss of vision is from about 6 months onwards due to retinopathy or radiation-induced retinopathy, optic retinopathy, neovascular glaucoma. Cataract, we still want them to have the cataract done, but ophthalmologists need to look into it and assess the disease. Dry eye is not as a big an issue as I initially worried about, and secondary nucleation is due to the disease. 2 more slides to say where are we up to now. We've improved our technique with a better mask to help immobilize the head, which is more comfortable. And courtesy of our in-house physicists and radiotherapists, they've 3D printed this attachment to the frame. And we bought a new camera system, which is 2K quality, attached to with this holder that's also 3D printed, with a mark for the patient to look at rather than light. And it's centered, it was in the center rather than to the side, so that patient can see with either eye, now without having worry about looking at, from the diseased eye. And the physicists came up with a software program where you can, so this is showing the more comfortable mask immobilization. The physicists come up with this software where it instantly captures the outline rather than using a plastic sheet and texture. Now the computer does this, so it instantly comes up with all these outline, which it's also outlined the eye like this, and that's the camera in the center with a crosshair there for the patient to look at. And we started this year, and it seems to go really well. We tested first on the radiotherapist and the physicist. The radiation oncologists opted out. They want to be claustrophobic. But without the machine being turned on, but just testing the mask and the camera system before we went live for patient treatment. So in conclusion, the advanced radiation technique with linear accelerator based stereotactic radiotherapy with external eye fixation system is a non-invasive technique that's reproducible for patients with UV melanoma not suitable for plaque brachytherapy. It offers excellent tumor control, safe, similar toxicity profile to brachytherapy. And so we've saved almost 200 patients from needing enucleation, preserving the eye and its function. Right. So I've gone a little bit over time. We'll open the floor for questions. So just looking at the Q&A, it's asking what's the feedback from your patients. I might have to expand on that, whether that's asking is I was asking the radiotherapist this question. Is we can't really ask the patients what they think of the new system versus the old system because we haven't tried it. But we believe the this immobilization mask is more comfortable than the previous ones, especially when we don't have to use that bite block. It's very hard for patients who have to bite on that. We use a dental a mole to create their comfortable bite. So from that point of view, it'll be better. So also, Lotte, what is the feedback from your patients? Maybe I'll ask the other two questions first. I must have missed this. Why wouldn't we choose a patient with juxtapupillary lesion for stereotactic radiotherapy? Exactly. That means also what Tim alluded to. It all depends. It might be juxtapupillary. It'll be suitable radiation regardless, but it all depends on how much useful vision they have. So on the slide in which I didn't emphasize, all depends on the vision as well. That visual loss as non-functioning eye, so patient may be more comfortable having the eye removed anyway. But yes, you could say all patients could be treated with stereotactic radiotherapy regardless of the position, or all patients with juxtapupillary location. The toxicity from radiotherapy, the vision is loss is permanent just due to the radiation retinopathy, neuropathy, but there is treatment for it to stabilize it. So the vision won't reverse, but it can stabilize it rather than, because the damage is permanent to the retina and optic nerve. They don't recover from radiation. The question was, what is the feedback from your patients?
Can I answer that?
Yeah.
So the main feedback we had from our patients in Melbourne is that there was a lot of information available about enucleation and other procedures they could have, but not very much about plaque brachytherapy. And some of the patients had really basic sort of feedbacks like, I can't read, I wish I'd known, I would have brought music or audiobooks, and a whole heap of other questions. So we've put together some videos. Some of it is videos of patients and of our clinical nurse consultant talking about the patient experience, and some of it's more informative to try and help them understand exactly what happens sort of step by step through the plaque brachytherapy process. It's very nearly complete. We look forward to sharing it with you.
So that is there's a follow-up question then. Where will the resources be available for the patients?
That is a great question that I actually don't know the answer to, but we will, I hope, be advertising it through AOMA. We're probably not too far off being able to share it with patients, but we'll be sharing it certainly through the Eye and Ear Hospital website, but also probably elsewhere. If anybody is very keen on seeing it, please send me an email. You're very welcome to share my email with everybody on this call, and I will cheerfully share it when we can.
All right. Well, it's coming then. I think there's no more questions on the Q&A. Just another plug for those online who are intending to donate. There's still time. Go on the QR code